All right. So welcome everyone to our weekly orthopedic surgery grand rounds. We have a very special visiting professor. Dr. Hansen will introduce him shortly. Just right before we start, I want to acknowledge our fourth year residents. So fellowship match day was yesterday for most of them, except for our future hand surgeons. But I think we had a great match outcome. So Stephen Garcia going to Boston Children's. Kaz going to Stanford for arthroplasty. Ellen going to Rothman for arthroplasty. Sergio going to USC for sports. Alex to Pittsburgh for sports. Sorry. Fabian to Rothman for shoulder elbow. Aviana to NYU for spine surgery. And AJ to San Diego Spine, also for spine surgery. I think that's everybody, correct? All right. And then Joey and Sarah yet to come, but I'm sure that'll be outstanding. So congratulations. I think everybody did really well.
Congrats again to the PGY4s on that incredible match. It gives me great pleasure to welcome and introduce our visiting professor, Dr. Matt Austin, for this morning's grand rounds. I've known Matt for about 13 years now, since he served as the fellowship director when I was at the Rothman Institute. And our two institutions have had a very strong relationship over the years. Many of your current faculty and past residents have done the Rothman Fellowship, including Drs. Diaz and Ward, as well as Kevin Chu, Michael Feldstein, Trevor Grace, and Musa Zaid, who's here in the audience this morning. Welcome, Musa, back. And we have more to come. So we've got Hunter Warwick and now Ellen Say. So congratulations to you all. Dr. Austin made a very difficult decision to leave a very successful practice in Philadelphia to move to New York and join the group up at HSS. And I have a bit of mixed feelings about that because I've always encouraged our residents to go to the Rothman Institute. And now I'm going to have to basically begrudgingly say to put HSS on your short list because you'll have the opportunity to work with a great teacher. So I won't rehash his CV. He's clearly shown himself to be a clear leader in our subspecialty. He's got triple-digit publications. He's been recognized for every named award in arthroplasty research, and he's probably one of the youngest inductees into our prestigious hip and knee societies. But what really stands out to me is his humility, his compassion, and his commitment to mentorship. And I consider him to be one of my most impactful career mentors and the best surgical educator I've ever had. So welcome, Matt, to San Francisco, and we look forward to hearing your talk on value-based care.
Well, Eric, thanks for those kind words. I'll try to not make a liar out of you. So here are my conflicts, and I actually don't have any conflicts related to this talk. So this is truly a wonderful place, and I really mean that. The quality of education you get as residents here is truly amazing, and I think it's a testament to the program that the match went as well as it did yesterday. And it's not a surprise because I think it happens year after year. And so congratulations, Tad, on building a great department, and Ben for taking it over, and I'm sure bringing it to new heights. So as Eric intimated, I've known these three guys for a long time, and there's a lot of awards and accolades ascribed to them already, but they're all wonderful people. They publish a lot. And, a testament to Claudia, who had no resources in Chile and continued to publish. That is really something special, but I've known him a long time. So these are pictures from interview day at Rothman. On the first two pictures, there's a lot less gray there. And this is Claudia when he was doing a research fellowship, and that's Dr. Rothman, to whom I'm indebted as a mentor. And there's some other characters here. You recognize Derek Ward, Mike Feldstein, and all the characters that were named. Ellen, I didn't have a chance to put your picture up because you didn't match yet when I made the presentation, but congratulations, you're going to a great place. And this guy's in the audience, and he's quite the character. Just look at the license plate. But he's also very thoughtful, and he's a great photographer. If you haven't checked out his Instagram, it's really great. And he gave me this picture that hangs in my house. And he said it was a reminder of the effect that, I've had on San Francisco. And, it was really the team effect that Dr. Rothman put together. So it's a special bond. And that's why when I got the invite, I couldn't wait to get here. So I'm going to try not to be yet another boring talk by a joint guy. I'm going to try to make it applicable to all specialties. And I am going to talk about discharge planning, bundled payments. I don't have any surgical videos. So if at the end you look like this, it's fine. I understand. So here's the challenge we face. Healthcare has changed. We've evolved from fee for service to value-based. There's a lot of carrot and stick methodology forcing us in that direction. But the bottom line is we want to provide appropriate care to our patients in a fiscally responsible way. What got us here was unsustainable cost, a variation in quality, and a lack of coordination between the different aspects of healthcare. And it's come home to roost. Joint replacements cost Medicare alone, which are our poorest payer, $7 billion. And that's not counting the commercial payers. And so what goes into this cost? Hospital choice, where we do the surgery, the post-discharge care of the patient once they leave the hospital, and readmissions when they come back into the hospital. So what's value-based care? It's a concept by Michael Porter and Kevin Bozick, who used to be here, was instrumental in a lot of these concepts. Value is outcomes divided by cost. The thought from Michael Porter, who's a Harvard health policy specialist, was that providers would compete for patients along with healthcare purchasers, and that patients would become a more critical consumer of healthcare. So there are these alternative payment model programs. Basically what they do is they take all the services that we do, both pre, intra, and post-admission, and bundle them into one payment. And it's up to us, healthcare administrators and surgeons and other providers, to sort of whack that pie up. And who controls that pie is incredibly important. If you're familiar with the RUC system of how physicians get reimbursed, it's a brilliant system, actually. There's a pie. They put all the doctors in one room, and we fight over the pie. So we're the bad guys, not the policymakers. So it's a brilliant strategy.
All right, everybody, hands in the air. All right, now I want you to take off your helmets, go outside, and dig your own graves with them.
That's kind of dark.
Shut up. There's enough cutesy crap in this movie. I think we all need this. Now get outside.
I have a family.
Faster.
I just do data entry.
So it's a system that's similar. The RUC system is similar to the system that's used here. But the problem with value-based care is it may neglect a patient's personal values. It turns a trust model into a targets and performance model of healthcare. Professional ethics in terms of how we take care of patients gets mixed with business ethics, and physicians feel the stress and loss of ownership. And I think we all feel that in this room. So this is our institution, or my former institution's journey through this value-based care. And this road continues on. You see it's a little rough in the beginning. I took this picture in Hawaii. It's a little rough in the beginning, and then it's paved, but it continues on because the story does continue on. So a few facts about Rothman are a little different than UCSF. It's a large private academic practice, and we negotiated to control the bundle, not the hospitals. We're affiliated with many health systems, which gives us options in terms of where we take our patients. We have ownership in specialty hospitals and ASCs, which gives us further options. Rothman's an S-Corp that's owned by the shareholders, And therefore, the shareholders share in the entire risk reward when we entered into these payment models. And I give Mike West, our former CEO, credit in that he took the risk and entered these models. And these were some of the models from the mid-10s that we entered into, including a CMS model I'll go more into. So this is what an episode of care is. Basically, it's, the initial encounter of the patient until they're basically 90 days out. So the pre-op part of it, and this is where bundled payments were good. They forced us to focus on this medical clearance idea. This is an actual clearance note from about 2010. We got some labs and we got our friendly guy to clear the patient. What that meant, I'm not quite sure. But after bundled payments, we had this risk assessment form where we identified just how at risk the patient was and how we could intervene to maybe make that patient somewhat healthier. This is something we were doing actually before bundled payments. We had a group down at the Jersey Shore who had a wonderful pre-admission process to optimize patients. And we sort of took that model and expanded it. We hired a nurse navigator group, and the nurse navigator was really responsible for the patient's entire perioperative episode of care. They were in control. They were making sure the patients went through the right steps. And this is a busy slide. It's just the take-home point is there's a whole process before the patient gets to the operating room of trying to make sure the patient has their risk profile as optimized as possible. And we showed that this is actually cost effective. It costs a lot of money to put these programs in place, but we actually, through the value-based care programs, were able to show that there was a financial benefit as well as a patient benefit. And then we discovered there's different types of risk factors. There's modifiable, non-modifiable. There's a controlled hypertension or uncontrolled hypertension. And we really focused here on these diseases to see if we could improve outcomes. And when we talk about risk, are you going to be a cowboy and operate on everybody? Or are you going to be afraid to operate on people? And I think I showed in the case presentation, I was afraid to operate on that patient. The primary considerations, of course, are the patient quality of life, the risk of complications, and the risk of not operating, which is often not looked at. And then all these other secondary considerations came along with value-based care. And really, there's only a couple areas where you can try to mitigate risk. I hate the term preventing complications. There is no prevention. You can only reduce the risk of a complication. And that's what we were trying to do here. And we know through the work of Max Courtney and later Chad Kruger that readmissions are really, really expensive. And we wanted to try to avoid those. And they're a huge expense to the patient in terms of a lot of mental anguish. And so we looked into, can we predict who's going to lose us money? That's what we were looking at here. And the answer, when you look at these receiver operator curves, is no. People are not airplanes. We can't predict, at least with the statistics that we have and the numbers that we had. So that was a little disappointing. In terms of perioperative processes, we learned that if you write it down, and most importantly, you measure what you write down. So in other words, if you have a preoperative guideline, how many surgeons are following that? If they're not, why aren't they? And how can we incentivize those surgeons to follow those guidelines? And I'll show you how we did that later with an example. So we wrote down everything. If someone had a low pulse ox, what do you do when someone has a low pulse ox? So it was a resident. His name is Harvey. When he was on call as a second-year resident, he would order a spiral CT on every single patient that had a low pulse ox. And Jay Parvizi actually published on the effects. Our rates of VTE went through the roof when Harvey was on the rotation. He's a spine surgeon. Sorry, I can't help myself but dig at the spine surgeons. But anyway, so that we came up with this protocol, and we showed that we weren't missing pulmonary emboli, but we were reducing the number of unnecessary workups and unnecessary anticoagulation when we followed this protocol. We published on that as well. That's just one example. I'm going to focus mostly on post-discharge care at this point. So think about who takes care of our patients in the operating or after the operating room. Why do all these services exist? And if we're honest with ourselves, it's because we didn't really want to take care of the patient. We wanted to operate and then have someone else deal with the patient, right? We didn't want the calls. We just wanted to do the surgery and off they went. But through value-based care, we found out that the best team taking care of the patient is your team, because there's a reason why we do everything that we do. And you want your team executing that, not someone who is trying to do the right thing. It's not their fault. They just don't have the education or background to do so. So prior to 2014, before we entered into our first value-based care agreement, over half of the cost of joint replacement was post-discharge. And you can see these are actual surgeons. And you can see the difference in post-discharge costs went anywhere from $502 to $17,000. Same surgeon, different surgeon, same operation, different costs. We said, why is that? And Mike West came up with this concept of demand matching, which is Rich Iorio's concept actually for implant use that we took and stole for post-discharge episodic care. So as you go from the left side of the screen to the right side of the screen, it gets more expensive because there's more facilities involved. So we thought like a healthy patient who's pretty active before surgery could just do self-directed physical therapy. Some patients who maybe aren't as active before surgery, maybe they need some outpatient PT. The truly older patients or disabled patients, maybe they need some home health, or maybe they need to go to a rehab facility. Right. So in 2011, this graph basically shows if they went home health with SNF or an inpatient rehab facility. And you can see in 2011, about a third of our patients were going to a rehab facility and 55% were going home with home health. That's home PT, home nursing. Fast forward to 2018, you see majority of patients went home without any services. That doesn't mean they didn't go to outpatient therapy. They just didn't get in-home physical therapy. So by 2018, we had reduced the cost of post-discharge care to being about a quarter of the episode of care. And we were huge winners with the BPCI first model. And the practice was a huge winner. And I'll argue that the patients were a huge winner because I think we were providing much better care. So how did we do that? Well, we were a bit forced, right? Because we were on the line.
Okay. Starting here.
Excellent pain management is really paramount. And this is a patient who's just a couple hours after surgery. And it doesn't matter what multimodal program you use. It's just that you use a multimodal program. And so I'm asking her, how is your pain? How are you doing? What can you do with your knee? And honestly, this is not like a minimally invasive talk where I'm just showing the one patient that did well. I'm showing a pretty typical patient with this multimodal pain management program. And then we show that you can reduce the narcotic intake by a third by continuing the post-discharge medications, the post-surgical medications once they've left the hospital. Counseling is important. You have to talk to the patients. Everybody has to be on the same page. One person tells the patient they can go home to rehab or go to rehab instead of home. Guess what? They're going to rehab. So there has to be consistent messaging. But you know what? At first, the patient will still make demands.
Happy birthday!
No way.
Happy birthday!
Yeah, you don't know how hard it is.
Oh, Mackenzie, it's fine. Come on, Mackenzie.
Right, stop filming.
But, Dad, it's off.
So anyway, you have these patients and they have certain ideas because their relative got it a certain way, or maybe they had surgery before and they went to rehab. So we had to come up with a story, a reason why they didn't necessarily need these services. So this is Kevin Bozik's paper. It showed top graph is 30-day adverse events. Bottom graph is 30-day readmissions. The sort of dotted line at the bottom is if they went home The top line, the top two lines are if they went to a form of rehab, and you can see that the rates are much lower when patients went home. So rehabs really aren't safe for most patients. Some patients do need a rehab, but most don't. And they really do unnecessary tests. They send your patients to the ED because they have a swollen calf, and all of a sudden we have a lot more readmissions, more potent anticoagulation, and off we go with a higher infection rate. Patients will say, I need home care. At the end of the day, what does home care really do? They don't do a heck of a lot, but they do add a significant amount of cost to the episode of care. So we got rid of home care. Oh, but I live alone. I have to go home. I can't go home. I have to go to a rehab center. It's not safe. This drove Bill Hozak crazy. So we did this study, and we showed that, yes, if you lived alone, maybe you stayed overnight. We stayed a little longer. Maybe we used some more home health services. So it's not like we just cut people off. You give people what they need, and you don't give people everything routinely. But if you stay a little bit longer, you get some home services, most people can go to home, and almost 90% of the patients have said, I would do it again. And these are people who lived alone. My personal pet peeve. But I need physical therapy because it will help me recover better, faster, higher, stronger. But do you? Do you? Do you need someone telling you that your total hip patient that they're an inch long? I don't think you do. So we did a prospective randomized study for hips. One group did a home exercise program. The other group had formal therapy. There was no difference in their Harris hip scores. Well, but knees are different, are they? The change in flexion home program versus web program versus paper program, was it really that much different? There wasn't a real change in scores. But insurance companies, as a result of those two papers, started to push back and say, well, we're not going to pay for PT for anybody. And so what we wanted to do was say, that's not the point. The point was not everybody needed it routinely, but some people do. And about a third of people do need physical therapy post-operatively, formal therapy. It's not like they're not getting therapy. They're doing the exercises every day on their own, and we're checking on them every couple of weeks to make sure they're progressing. If they're not, then we give them a script for PT. And about a third need it. 2/3 can do it on their own. So this is a quote about the Kremlin. I would say it's pretty equivalent to CMS. They changed the rules in the middle of the game. So we were flying high. We thought we could do anything. Patients were doing better. We had low complication rates. We were making money doing it. So we thought, let's try something even better. So here's what happened. There was something called BPCIA, and we took a real bath. So we were making about $1,500 a patient in the first version. When you look at the second time period with BPCIA, we had a lower rate of readmissions than in the first BPCIA. We had a lower rate of discharge to facilities. We had a similar rate of complications. There was no difference in medical comorbidities. We weren't lemon dropping and cherry picking. And our quality data was in the top 10%, according to the convener. And we lost $890 a patient. You may say, well, who cares? Well, with our volume, over the first 3 quarters, we lost $2.1 million. And remember, it's a S Corp. So all the shareholders shared in the pain. They weren't very happy with us. So we said, peace out. We're not doing BPCIA, and we dropped out. But we still lost the $2.1 million. Why? Well, it's about statistics. There's lies, damn lies, and statistics got us. So this guy is Charles Windsor. He's a statistician. And when you Windsorize, it's the limiting of extreme values in the data set to reduce the effect of outliers. So, for example, a 90% Windsorization of all data below the 5% set to the 5% and the data above. So you take the bottom 5 and the top 5 and you throw them out and you use the data in between. Well, for BPCI, Rothman chose to Windsorize the bottom 5% and the top 25%. For BPCIA, everybody, including Rothman, was forced to accept Windsorization of the top and bottom 1%. This made a huge difference. Below the red line is a loss, above the red line is a win. That really affected us. And there were other reasons. Our target price was adjusted, punishing good performance, because it compared our previous 3 years rather than the original baseline data. So it was a race to the bottom. And readmissions unrelated to the index surgery counted. So if a patient came in at 89 days and they needed a carpal tunnel done, guess what? That went against our bundle. Doesn't seem fair, but it is what it is. So we're not very smart, so we kept going with bundled care programs because we're pretty optimistic. So now comes along site of service. So you have total knee arthroplasty first, no longer an inpatient. Why they chose that first, I have no idea. Dad, I don't know if you know why, but they went with knee and then hip, which again doesn't make any sense. And it's a huge opportunity for ASCs since now we could do total joints and ASCs. And this is a slide that shows the variation in the facility reimbursement for the same procedure. And this is Philadelphia data. I'm not even showing New York data, which there's usually a 0 after some of the numbers, an additional 0. So we took that demand matching concept and we took it to this kind of site of service because, again, this is where our practice was a little different. You have different places we could take our patients, ASCs, specialty hospitals, community hospitals, and then the university hospital. And as you go from the right to the left, again, the cost increases. But sometimes if you have a patient who's had 3 heart attacks or stroke, maybe an infected spine, like the case we showed earlier, maybe you're going to not take those to an ASC, you're going to take them to a university hospital. That's what they're there for. So we use this demand matching concept to that. And we showed that you can do it safely, and we found out different reasons why you couldn't send a patient home same day versus next day. But it's really a change in the thought process around the surgery. This is more mental than anything we've done from a protocol standpoint. This guy's 8 days out. He's a little bit of a interesting guy. I'm trying not to get myself canceled here. He's a very successful pharmaceutical executive. He was also in like American Ninja Warriors, West Point grad. So he's a little bit of an outlier. Holds the pole vault record for his age group. But it's an example of how people can think differently about the process. And it required a stepwise change in mentality, a lot of which we learned through the bundled payment programs. And COVID was a big help when you transition people to same-day surgery, because who wants to be in the hospital when there's this terrible virus ravaging the world? So if you notice, the keys to success in outpatient total joints are basically the keys to success for inpatient surgery. It's just getting people, getting staff, getting everyone used to the idea of sending someone home the same day. And it's important to standardize care, whether you're doing same-day surgery or not. I'm sure that you are all doing it here. It's a change in mindset for everyone, the surgeon, the staff, the patient, and the family. It's important that the surgeon and staff are on the same page. Allow the staff to help you design these programs. This is that same guy. Obviously, he's an outlier. That was the next morning. Not happy he was doing that. But this is, someone asked me yesterday, like, I think it was Eric. He said, well, what's your passion behind research? And I like looking at stuff that we do already. And I like looking at it and making sure that we really need to do it. So I don't think we really need to get post-operative labs on most patients. I don't think anything stronger than aspirin's really needed post-operatively. I don't think we should be doing bladder scans routinely on people. We do these because we think it's safer, but sometimes it introduces more problems and more complications. If you're going to send a patient home the same day, I think it's really important you provide them with your team's contact information, if not your team yourself. I operated on Monday. I called my patients Tuesday morning because I want to make sure they're doing well, and I also want to make sure no one's telling them the wrong information. Make it easy for the patient to see. You may think it's painful, but there's nothing more painful than a mismanaged patient who gets admitted to an outside ER with a DVT that really gets over anticoagulated. They then start draining, get an infection. That's really painful for everyone involved, especially the patient. And here's the last part of the talk. How did we get these people here who are very strong-minded, very strong-minded, and very smart? How do you get them to buy into all of these changes, right? Because while we didn't want to lose money, we wanted to provide the highest quality care. And some of my partners truly believe, don't be part of the problem, be the entire problem. So how do you get them to cooperate? Well, you get a great person like Chris Manella, who's in charge of our Nurse Navigator program, who was a nurse, who understood how to talk to doctors and get everybody on the same page and make it about the patient, not about the money. That was really important. And then we started generating metrics, because guess what? When you get information from payers, it's really granular. You know the readmission rate, you know the complications, you know the risk profile, and you know how much money each patient gained or lost. It's powerful information. And we presented it in surgeon report cards, and still people didn't want to change. So I said, how can we get people to change? Who am I dealing with? I'm dealing with really competitive people, right? Who really care about patients, but they want to be these are people all used to being at the top of the list, not the bottom. So I said, we always show this data blinded. What if we unblinded it and showed it to everybody at every joint meeting every quarter? Dr. Vale's looking pretty good. Not Dr. Austin. I don't like that. How can I change? The doctor at the bottom that's better than Dr. Vale, that's Dr. No Operate. I don't know how you have a 0% complication rate. But this was a really powerful tool, right? Because nobody wants to be at the bottom. And we showed this for everything. How many patients are, if we have let's say a hemoglobin A1C cutoff, how many went above that cutoff? Dr. Ward, you did 10% of your patient population in hemoglobin A1C above 8. We all agreed on 8. Why is that? Really powerful way to get people to do the right thing. And they said, wow, my patients are more complicated. Are they? Because we put the risk stratification right up next to the outcomes. And Jim Pertil consistently at Rothman had the lowest complication rate. People say he's lemon dropping and cherry picking. Then we put up the risk stratification. He wasn't. He was operating on some of the more complex patients. So he was doing something right the rest of us needed to emulate. At the end of the day, it should be about improving care for the patients. Don Berwick, who is an administrator with CMS, said that the central law of improvement is every system is perfectly designed to achieve the results that it achieves. So you have to design a system that works. So in conclusion, value-based care is here to stay. Government and payers are really addicted to the cost savings, and we have to protect patients at the same time. So there is a good, there's a bad, there's an ugly to this value-based care. But I would hope that it's all evidence-based as best as possible, and that's what we strive for. And that's really the conclusion of my talk. I'd like to thank you for inviting me. I'd like to thank everybody who's shown me such great hospitality here. This is a special place in my heart here. And this is what Eric and Carlos Aguirre gave to me that hangs on my wall at HSS to this day. It shows their year. The kids are little, one kid, little. And it was a wonderful time. And I think with all the fellowships that everyone is matched into, I think you're going to have a wonderful time at all those institutions because they're great places. So congratulations on being here. Congratulations on your future. And Ben, I wish you well. Thank you.
All right. Thank you, Dr. Austin. That was great. And thank you for making the trip out. It really means a lot to us as well. And I think we have some time for questions. Any thoughts from the audience there?
So, Matt, I certainly want to thank you personally for your mentorship. I echo Eric's words that you're one of the most impactful mentors I've had in my entire career, and I mean that from my heart. So thank you again. Thank you for being here. My question is really, we had a similar experience with BCPIA. We did very well in BCPI, and we're sort of all patting ourselves on the back, and we thought we were good partners for CMS, and it kind of seemed like things are going okay. And then BCPIA dropped, and it really was, the race to the bottom. And so we also dropped out. And I think that's been sort of a little bit of a travesty in value-based care. But I think it taught us a lot about who really has the incentives here. So my question has been sort of like, as a society, as an orthopedic group, and I'm not just talking about hip and knee surgeons, because value-based care sort of is now sending its feelers into every aspect of care. What do we do as a society to protect patients, to sort of take the good from value-based care, but try to prevent the ugly?
Yeah, that's a tough one. And I think that's what we rely on the academy and for joint replacement, ACUS. Support those PACs, because that's what a lot of the money goes to, is interacting with government and payers to try to preserve care for patients. With the downward pressure on the economics for joint replacements, it's hard to make the math work if you're taking care of only Medicare patients. Greg Dermigian showed that with revisions, and others have shown it for primaries. I don't have an answer as to where it's going to go. It may go to a dark place where it's basically a public-private system, and if you have Medicare, you'll have a hard time getting access. I think patients are shocked at how much we get paid or how little we get paid. The average patient thinks we get paid about $50,000 for a total joint, whereas CMS pays us about $1,200. So if you think about it, after San Francisco or New York taxes, your overhead, you're probably taking home $250, $300 to do a life-changing surgery. How long can that go on for? I don't know. But the way to go about it is advocacy, patient awareness. I think we're reaching a point where the surgeons are willing to talk to patients, and hopefully the patients are willing to listen. The hospitals have always had a bit of an increase in their reimbursement, but the margins for joint replacements kind of get tighter and tighter for the hospitals. So you're asking a complex question that I really don't have the answer for. It's going to play itself out, unfortunately, is probably the likely solution.
Thanks, Dr. Austin, for a great talk. You mentioned a few things during your talk, thanks, that I just wanted to sort of follow through with. You mentioned the race to the bottom, and at some point in time, I think we would all think that, okay, we've reduced costs on readmissions, we've reduced costs on skilled nursing facilities, whatever. Maybe we include those, we buy them, we control them, et cetera, et cetera. At some point in time, you're going to have squeezed all the juice that you can out of the lemon. And you also mentioned CMS moving the goalposts all the time, for example. And their target price has never gone up, it's always gone down. So where do you end up with that? At what point is it, okay, we've done as much as we can?
Yeah, it varies from institution to institution, because there's a lot of fat, so to speak, that can be cut from many institutions. UCSF, Rothman, HSS, they're sort of on the forefront of a lot of health policy issues, but many places aren't. Our field is threatened because we have a lot of the say in the hospital and the operating room time because of the margins that we provide the hospital. And once the hospital's margins go down, we lose a lot of say. And, as sad as it is to say, like the pediatricians and the infectious disease specialists don't have a lot of sway at the hospital. We do, simply because we make the hospital money. And what happens to our field if we're no longer making the hospital money? What happens more importantly to access? Because if we don't have the operating room time, because we're not making the hospital's margin, these really great surgeries, there's shoulder replacement, hip replacement, knee replacement, ACDF, all joking aside about the spine service. These are procedures that are life-changing, that provide savings to society in general because we return people to work, their quality of life, and that access is going to be severely threatened. And I worry that more and more will go to ASCs that are going to be owned by physicians and ASC groups, and you can only get a joint replacement if you have the right insurance, you're willing to pay out of pocket. And that's certainly should not be the intent. The access needs to be preserved for all patients, especially revision patients that we saw this morning. Who else is going to take care of them other than UCSF, right? Not many groups, but those aren't very profitable procedures for the surgeon or the institution. But you can't leave people like that just in a wheelchair and say good luck to you. That's not tolerable. So ultimately, it'll take the patients to rise up to get any change. Yeah, that's Anthony. I can't see. Oh, I'm sorry. This light's in my eye.
My attending. I'm one of the fourth years. I have a question. Currently on a service that I think the idea is behind setting expectations across the field, from the surgeon to the staff to the patient. And when you have patients that don't want to move, and the only kind of advocacy about them moving is coming from the surgical team versus everyone else who sees the patient daily, but more gives in to their pain and slowing them down. How do you balance that? And what resources have you found useful to setting the expectations across team members in the hospital that this is what we expect for our patients in terms of rehab?
So great question. So treat the team members like they're a member of the team, that you value their input, that you're not dictating to them that this is what we're doing now. So all of this took a lot of work. We got the nurses from the hospital, the therapists from the hospital administration from all the different healthcare systems we're associated with, and said, these are our protocols. What do you think of them? What would you add? What aren't we thinking of? And if you give them buy-in into the process, then they go along with the process. If you dictate to them, what does someone care that's a nurse on the floor? What do they care where the patient stays or goes home in terms of the value-based care program? They're just trying to make the patient happy, take good care of the patient. If the patient wants to stay overnight, no big deal. But if you show them the data on extended hospital stays and you say, what can we do to safely get this patient home? Most people in healthcare are there because they care and they're willing to help. And if you make them a part of the team, it's not hard to convince them to have the party line because they're the party, right? It's really helpful.
Matt, I'd like to thank you for your support over the years and for that phenomenal presentation. My question, Matt, is during the last 15 years, we have seen a phenomenal improvement in the denominator part of the equation. We have observed your research, and we are a lot better than we were 15 years ago managing costs and decreasing costs. My concerns are regarding the upper part, the numerator. You are aware of this, and probably many of the attendees in the room too. The CMS will put a rule in a year or so, saying that the success of the surgery will be defined whether you accomplish 20 points using the HUS or the KUS durance, actually 22 for the knees. How do you envision that, let's call it black or white, sort of outcome to define success?
So there's different ways to define success. Is it the MCID? Is it the PASS score? Is it a delta? Right? And then, first of all, there's a problem collecting the data. Others and we have published that patients don't fill out those forms. What incentive do you have to fill out the form from Amazon about how happy you were with the delivery if it was just a routine Amazon delivery? If it's bad, you're more than happy to click the thumbs down arrow, right? So think about that from a patient perspective. They get bombarded with surveys. They got to fill out this long, computer survey about their experience. They have to fill out the, hospital surveys about their experience in the hospital. It's a big headache for the patients, but we're not going to get paid. Right now, it's the hospital's not going to get paid, but I'm sure it'll be the physicians who will get paid. And it's a brilliant cost-cutting strategy because you give people a benchmark that's going to be very hard to meet. And if they don't meet it, you just cut the reimbursement. So it's truly brilliant. I think they understand perfectly well what they're doing. Yes.
Well, number one, thank you so much for your talk. My question is, you brought up, an uprising of shorts should come from the patients. What does that look like? And I think you brought up the fact that some of the patients that are losing out the most are the ones who need it the most, who have the least resources. How do you mobilize that group? How do you mobilize everyone to care?
Frankly, I don't know if we can, but it would be through a collaborative effort, maybe with something like AARP, who speaks for a large majority of people. I'm getting their emails now, and I'm only 52. They want me to join. But they have a huge lobbying effort, and maybe that's the way. But unfortunately, part of me is defeatist, and I'm sort of like, it's just going to devolve into a two-tiered system where it's like Canada. You need a joint replacement. You wait several months to see the surgeon. Then you wait a year or two to get the actual surgery. And that's just the way it is. But if you have the money, then you get access more quickly. That's not like Canada. That's more like the European private system. That's really sad. And I hope I'm wrong, but I think that's the way we're going.
Dr. Austin, I'm one of the pediatric orthopedic surgeons. Dr. Marks is on our service right now. He's struggling against the nurses who protect the children against us. So that's why I asked that question. We used to say that when this whole movement came along, that a dollar saved is a dollar saved, a dollar charged is 30 cents. And so much of the emphasis in your talk is on the dollar charged side of it, the dollar earned side of it. Is there any effort on the dollar saved side? I mean, there are actually laws against that, but are we trying at all to show that when we don't operate, when we are selective, we are saving society? The problem is that we're up against the hospitals which want us to operate while they want to pay us less. And we're sort of trapped in that. And that's why you're saying you're fatalist or defeatist. But how much effort do we have any hope to go on the other side of that equation?
So what you're talking about is like a population health model, which is what, at Rothman we were thinking about doing, where you manage the entire arthritic episode of care, or, it's hard. Like in joint replacement's easy because it's only a couple operations and a couple diagnoses. Like something like pediatric orthopedics is actually much more complicated, right? Like, are you going to have a hip dysplasia bundle or episode of care? Maybe you will, but that's, I think, a long ways off. But I think it will come to, how can we do a population health model where we manage the entire arthritic episode of care or spinal stenosis episode of care, and you're given a certain amount of money and you kind of work from there. But then it becomes just rationing of care at the end of the day.
Sorry to follow up on that. So rationing has this real negative connotation to it, but just like we need to educate the patients on early discharge is good for them and the whole team, I mean, maybe we should be not thinking as much as rationing as just an education of patients and their alternatives to getting a knee replaced.
Yeah, I think that's absolutely. I think, yes, there certainly exists surgeons in the system that operate very aggressively. And, maybe like you're saying, having some appropriate criteria to operate. But I honestly think most of the people in our field aren't that aggressive. We're trying to do the right thing. And at the end of the day, it's the patients who are telling us, I need to have this done to have my quality of life back. Yeah, I'm not saying that there don't exist surgeons who are overly aggressive, but I think most people in our field are actually still trying to do the right thing. And at the end of the day, that'll save the system money if you're not doing unnecessary operations. But you have to think about it on the flip side. There's a huge amount of money spent on futile efforts leading up into surgery, right? The amount of injections, the viscosupplementation, the physical therapy, the days lost off of work. You're $1 in, 30 cents out. That's a really valid point, because when we look at the cost of joint replacement, the $7 billion, that's just what is spent. But what was saved by returning people to their quality of life and ability to return to work? People have looked at that and published on it, but nobody in policy cares about that. They only care about the money spent, because that's tangible.
Dr. Austin, thanks again for being here. We talked about this a little bit last night, but we spend so much of our time early on in our careers just learning medicine, learning orthopedics, how to be good doctors. We don't necessarily get a lot of exposure to this side or the business side really at all. And so, over the years, it's hard to find people that can advocate for us, with the knowledge that you may need to do so. So do you think there would be any role for like additional residency tracks where instead of an extra research year, there's like an MBA year, or, you learn public policy, or, you take an extra year to help gain some of the skills that might allow you to advocate for the field and in the future?
Yeah, so AUKUS has a health policy fellowship that you can do. That's really wonderful. The academy has different outlets for that, but you have to kind of seek that. I think we're poorly educated in business as physicians anyway, to start off with. It's hard with the work hour restrictions to add more things in and take away from the clinical part of our jobs. But I do think that business education is really important, and we're sort of, lacking in that in all of medicine. And I don't know how to solve that with the time constraints that we have.
Really enjoyed the talk. Question, you talk about eventually getting to a two-tiered system, like many other countries. What about the hospitals that are providing the care? HSS is going to be on one extreme side. Inner city hospital, underserved population is going to be on another side. So what would that look like in your mind? And how do we maintain equitable treatment to our population as a whole if we're going to a multi-tiered hospital system, if that's where we're going to end up?
Yeah, that's the danger, right? So the rich get richer and the poor get poorer. And then you have people in the inner city with very little access to care that need a revision surgery for a multiply infected hip, and they have a really hard time getting in to see somebody because it's a huge disincentive to take care of those patients. And there's a question of fairness, and there's a question of the Hippocratic Oath and us taking care of people versus the business model. And I showed the slide earlier in the talk. That's the downside of value-based care. It turns us all into making business decisions when we should be thinking about how to take care of the patient. How do you get, equanimity? That's a hard one, right? Like Tom Faring is really pushing this idea of trying to develop infection centers where you have these centers around the country where patients get referred to and they get the best level of care. But how do you fund that? How do you fund the travel for someone to go from, let's say, the centers in San Diego for California, from San Francisco to San Diego, right? Like, how is that funded? How do you show value in that? Those are all issues that, we can't even get both sides of Congress to talk about, where they're going to order the coffee from, let alone these bigger issues.
What would you, if you were czar, how would you, plan for that?
Wow, this has the potential to make me into a real monster. If I was king for a day, I would have specialized centers that received funding and had to show superior outcomes for that funding in order to maintain it. A competitive system where things are transparent, sort of like a expanded version of what we did with the surgeons. But that will never happen. It's too many politics. It's too complicated. I'm really worried about our field. And again, I don't mean to be down, but I don't see a way out of it because I just see a cycling spiral of lower and lower and lower race to the bottom. And then what happens when we get to the bottom?
Hey, Matt, thank you. I'm going to switch gears and talk a little bit something other than arthroplasty. And, I think
I can't.
You have shown a lot of, great success about building teams, getting alliance. That's what Rothman has been able to do, kind of get people to, work together, and people know I'm kind of like metrics. I like to look at numbers. How do you get those numbers, that you think is valuable, like risk stratification, who's doing in the background, where's the resources coming from? And also when you show the numbers, obviously we're competitive, we want to kind of do well, but there's also a human side of it. When is it too much that this is negative, that, you get the feelings hurt? How do you actually kind of show the numbers and how it changes? That's my question for you.
All right. So I'll start with that. You can tell that the numbers impact change because we show a graph every year that takes the quarterly numbers and shows how someone is doing. Unfortunately or fortunately with joints, infection rates are fairly low, right? So if you get one infection one year and no infection, you have a bump. So over time, you see the pattern, right? And to be honest with you, I don't really care about hurt feelings because at the end of the day, hurt feelings, they're nothing compared to an infected joint or a readmitted patient. And our product are our patients. And so I didn't really care about hurt feelings, but I do care about too much data. So we would focus on certain things, like we would focus on hemoglobin A1C for a quarter and say, this is what it looks like. A third of you are still operating on patients with a hemoglobin A1C. Why? And then we had a committee and I generally hate committees because committees don't have a conscience and they don't get anything done. But this committee was great because a surgeon would be like, hemoglobin A1C 8.2. Okay, that's hard stop. However, it's not a hard stop because the endocrinologist said that's the best that we can do. We can't drive it down any lower. This patient has osteonecrosis of the femoral head and it's collapsed. They need to get the surgery done. So it went to this committee. The committee reviewed it and they said, absolutely, it's reasonable. So the hard stop really wasn't a hard stop. And then those patients got extra special attention from the nurse navigators. And when you ask where the data comes from, it came from the nurse navigator program. That program cost about $1 million to set up, plus the carrying cost every year. It was borne by the partnership. It was more than paid back through the value-based care program. So any overhead was taken care of first before any of those shared savings were distributed. And only a percentage of those shared savings were distributed to the surgeons. The rest went back into the program. So that's where we got the numbers from, in addition to the payers who gave us that granular level data because we were in a data sharing agreement with them.
All right. Well, I think we'll wrap up there. But Dr. Austin, thank you so much again. And we have a plaque